So how's weather with you, Marion? Must be gorgeous at this time of the year?
It's beautiful right now. It really is. It's unbelievable. So yeah, if sun is shining, just behind a lot of bags still.
Yeah.
Where are you now?
Sorry.
Switzerland.
In
Bern.
Switzerland, but I was just moving to another place. So this is why I'm surrounded by boxes.
So would you mind if I share my screen? Just to
Yeah, quickly. Yes, go ahead. Are you doing, Rima?
I'm doing, but it's not allowing me. Global team, are you allowing?
Yes, ma'am.
Because it's not, the desktop is not showing.
Yep.
Yeah.
Sure.
Okay. Can you see the slides?
Yes, go to
Yes.
slideshow. Move. Perfect.
Okay.
Okay, time to go start. 1 minute.
Good.
We should have 1 minute.
1 minute.
Did I exit?
Okay.
Yes, yeah. You're already exited.
Okay.
Very good evening. Once again, it's been sheer pleasure interacting with all of you months after months, and it's 28th month in a row. And it's always a pleasure to see all of you joining, despite it being a Sunday evening and different parts of the world, and the questions and the views we get even after the webinar is over. Thank you very much, everyone, for being with us. And as usual, those of our speakers who are joining us for the first time, we do have a Q&A box where all our friends and attendees keep on typing the questions. So please keep on checking the boxes and keep on replying, to your talk or any other general topic. For CME credit hours, you will receive an email after the webinar, within 2 days of the webinar, and you will have to give your inputs and the certificate will be sent out to you. With this brief introduction, I'll pass it on to John Kempen and Rima Bansal, who are going to take forward the proceedings of the webinar. Welcome all.
Welcome to our 28th webinar on uveitis, which is going to be about macular edema, uveitic macular edema, a very important topic for all of us since it's perhaps the leading cause of visual loss. And we're going to start with the pathogenesis of uveitic macular edema by Professor Dr. Sapna Gangoputra. Dr. Sapna Gangoputra is an associate professor at Vanderbilt University and has a long experience in many papers about uveitis, and we greatly look forward to hearing from her. She's sort of one of the rising young stars in our field. Sapna.
Thank you, Dr. Kempen, for that very kind introduction. As Dr. Kempen said, thank you all. I am really honored to be here, part of this very robust panel with esteemed colleagues. And I'm going to start us off by talking a little bit about the pathogenesis, because understanding of what actually happens helps us to manage and diagnose the disease in a much more efficient manner. I have no financial disclosures, but I am very honored to have NEI grant funding. So the standardization of uveitis nomenclature has designated macular edema to be a structural complication of uveitis. So it does not associate itself with any of the anatomic locations. You can have uveitic macular edema with most commonly intermediate and posterior panuveitis, but you can also find it exclusively with anterior uveitis. And it is one of the most common causes of blindness and even visual impairment in patients with uveitis. The incidence varies depending on how you look for it. Most patients are, which you see in clinic with biomicroscopy, may not pick up macular edema as carefully as or as sensitively as an OCT would. My colleague, Dr. Monk, will be talking much more about the imaging characteristics, but I will describe some of the histopathological findings using imaging modalities. It is really important for us to understand macular edema because it has been associated not only with a decrease in visual acuity, but it also causes a decrease in overall visual function, affecting visual field, reading speed, and even contrast sensitivity. So our patients are really affected by the macular edema. The base premise of macular edema is described by Starling's law. So in Starling's law, any amount of fluid entering the retina has to leave the retina, and overall the retina has to remain dry. So if anything changes, there's more influx of fluid, or if there's a decreased efflux of fluid, and any time that this balance is off, we're going to end up with fluid in the macula, leading to what's called macular edema. And there are more than one factor that contributes to why we have uveitic macular edema. We know that in diabetes, this is predominantly mediated by VEGF. Therefore, we use anti-VEGF treatments in diabetic macular edema. But in uveitic macular edema, there's some elements of VEGF release, but there are also various other factors, some of which are structural. And this makes it really difficult for us to treat patients with uveitic macular edema. I was trying to understand and look for really good pictures that would describe this in histopathology. And I came across this beautiful book chapter, and I put it down there if anyone wants to look it up. It's a really lovely picture that explains this. So if you look at number A, this is where you have all of this is the inner retinal barrier. So this is made up of retinal capillaries and retinal blood vessels. And as you can see on the little bullet boxes on the B and the C, they have tight junctions, and those tight junctions need to remain closed at all times. And that's what keeps the retina dry from the inner side. On the outer retinal barrier is the RPE. And again, here, this picture shows you how those junctions are tight and must remain closed. But in an abnormal state, in a state where there's efflux, most commonly as we see, which is inflammation mediated, then you see that there's a breakdown of the scapulary wall, there's loss of pericytes, and when that happens, you then have efflux of fluid, exudate, proteinaceous material from the blood vessels into the retina. And similarly, if there is a breakdown of the RPE and those tight junctions are not closed, then that same efflux doesn't happen on the RPE side, and fluid starts to collect, as you can see here, in the subretinal space. So this is a really good picture that explains exactly what happens in macular edema. But let's look at it in OCT way, because we understand that a whole lot better. So first, I'm going to direct your attention to the middle one, to the cystoid macular edema. That's the one that we've been most familiar with because we look at the classic petaloid pattern on fluorescein angiograms. And what this is that the fluid starts accumulating in the Henle's layer. So Henle's layer lies radially to the fovea. And therefore, when that area starts swelling up, you see that classic petaloid pattern. But as time passed and we got more advanced with our technology, and we were able to get more and more OCTs, we were then able to understand that the differences with uveitic macular edema from your classic diabetic macular edema might be better explained by looking at an OCT and looking at what changes happen. So this is a really nice paper written by Dr. Sobran and colleagues. And here it describes the 3 types of macular edema. The one is diffuse. In this, and this more and more, we changed it in the BCSC book this year, because most of we want people who practice uveitis to realize that you may not see the classic cystoid pattern, but overall you'll see a sponginess of the retina. And so looking at the whole macular volume increase versus looking at one cross-sectional scan only of the central subfield may not give us enough information. And histopathologically, this correlates to the Muller glial cells in the retina getting swollen and therefore causing an increase in volume. But eventually, with time, those Muller cells then undergo necrosis. And now you start to see these cystoid spaces. I want to highlight this a little bit more because this is one of the other reasons why we see a difference between fluorescein angiograms and OCTs. So we know from data from MUST that OCTs and fluorescein angiograms don't agree always with regards to macular edema. And this is the reason, because sometimes the cystoid spaces could be degenerative. So you might not be able to, there's no exudative fluid, and so the treatment may not cause those cystoid spaces to disappear because it's from necrosis of cells. And lastly, the subretinal fluid, which we see also very frequently, this can be associated with leakage on fluorescein angiogram and pooling. And this is because of the separation of the neurosensory retina from the RPE. This is most associated with loss of vision and recovers most quickly when treated. So as I started to mention initially, early changes of macular edema causes changes, physical changes in the retina, them being the normal retinal transparency and changes in the refractive index. But these are treatable and will respond to treatment and reverse. But as time passes, the changes, if untreated chronic CME or recurrent CME, are then affect deeper capillary layers. And now with OCT angiograms, we actually can see those layers and see disruption of the superficial and deep capillary plexi, and then it starts to disorganize the inner layers of the retina and eventually can cause photoreceptor outer segment atrophy. This is seen on OCT as the loss of the ellipsoid zone. And so when we start seeing these later changes on the OCTs correlated with more damage on histopathologically, then we know that this visual acuity may likely not respond or reverse with treatment. And we can also use these histopathological changes now on OCT as markers of disease. So specifically part of 1 here, this is the drill or the disorganization of the retinal inner layers. And in the example above, you can see where the yellow arrow points that to some degree, it's hard to make out the layers, the inner retinal layers, inner nuclear layers. Whereas if you look at the lower one, you really cannot make out any of the inner retinal layers. And so this now has been explored in the visual study. So Dr. Jaffe and group published on it. It is not yet being used as an imaging biomarker, but hopefully in the future, we'd be able to understand this a whole lot better. And we talked about pro-inflammatory mediators. There are several pro-inflammatory mediators which are being explored right now. The MERIT study, we tried to use anti-VEGF injections, and then we use systemic medications. All of these will be covered in later talks today, but this opens various therapeutic opportunities for us to treat uveitic macular edema. And with that, I will close and be happy to take any questions. We want to wait for after everybody for our panel questions.
Yeah, I think we'll take the
so.
questions.
Thank you very much, Sapna. Very nice talk.
Thank you, Sapna. Wonderful elaboration of the pathogenesis, and I think it's a very difficult topic to understand and to comprehend. So with this, we now move on to our next topic of the session by Dr. Marion Monk. She's a uveitis and retina specialist, and we all know that she has an extensive work on imaging, especially in uveitis and retina. She's in the University Hospital of Bern, Switzerland, and I think the most appropriate person to talk on imaging considerations for uveitic macular edema.
Thank you so much for the kind introduction. I start to share my screen with you. All right, so I was asked to talk about the imaging considerations in uveitis-associated macular edema, and of course, as you can imagine, this is a topic I like a lot. Sapna, thank you very much. It was really a great overview of the pathogenesis of macular edema, and I may come back to a couple of points which you have already raised in your previous presentation. These are my financial disclosures, but none of them are relevant to this talk. So in the next couple of minutes, what you will hear, so I will briefly, but only briefly, because Sapna did already a great job, talk about the pathogenesis, and then about what you actually see on OCT, on fluorescein angiography, because these are the most two important imaging modalities when we are talking about uveitis-associated cystic macular edema. And then I will talk a little bit about characteristic morphological features on these imaging modalities, a little bit of correlation of anatomy and function, and last but not least, of course, a little bit about prognostic biomarkers. So why actually does macular edema in general occur? We already heard a lot about it. And what we see is actually there, we have in the fovea 3 capillary plexi, which actually form the anastomotic ring, the foveal avascular zone. And so we have a high density of blood vessels, which then cause a strong serum leakage. On the second point, we also have there the Henle layer, which courses laterally. You can see it actually here. And this is a great reservoir for the accumulation of fluid due to the fact that there are really very loose binding inner connection fibers in this Henle layer. So it's a very easy way where fluid can accumulate there. And last but not least, we have a watershed arrangement, which leads to the decreasing resorption of the extracellular fluid. And when we have a look at the OCT, what we actually see is nothing, because we see the structural visibility of intraretinal tissue-free spaces. So when we see a cyst, what it means, it's actually there is no tissue left. But the nature of these tissue-free spaces, they can be manifold. They can develop due to the exudation, where the retinal tissue is just pushed aside by the accumulation of fluid, but they can be also caused by tractional forces. For example, when we have patients with an apparent membrane in uveitis-associated macular edema, or of course due to degenerative processes, which primarily leads to the tissue loss, and then secondarily is filled by the fluid. And the spaces, Sapna has already touched on it, can also develop due to intracellular edema, which is also called cytotoxic edema, characterized by the cell swelling and the death of the milieu cells. And these presence of the cysts seen on the OCT may or may not be accompanied by the angiographic vascular leakage. So when we then have a look on fluorescein angiography in contrast, what you will see there is the leakage and not the cysts per se. And this leakage occurs because of the permeable vessels, and the vessels are in turn permeable because of the breakdown of the blood-retinal barrier. You already heard about it from Sapna, which means that the vascular tight junctions are dysfunctional and the larger proteins can just leave the vessels. And because of the fact that the dye is bound to these proteins, this is why you then see this leakage. And the water is just drained behind due to the osmotic gradients, because the proteins, they take a lot of water with them. So therefore, in general, what you can see on FA, you will only see the exudative macular edema due to the vessel leakage, but usually you don't see any macular edema due to any other causes. This is very, very important, especially when we differentiate macular edema of different underlying causes. But in turn, or in contrast to OCT, the fluorescein angiography is very, very sensitive. And in a lot of cases where you have an exudative leakage-induced macular edema, you may be able to see and appreciate a subtle leakage on FA, which does not translate into a cyst formation seen on the OCT or any retinal thickening on OCT, because the fluid can be cleared and absorbed before really large cystic spaces develop. The pathogenesis, you already heard of it. The main reason is the release of pro-inflammatory mediators, which then lead to the breakdown of the inner and outer blood-retinal barrier. The presentation of uveitis-associated macular degeneration on OCT is very, very characteristic. And because humans are very good in pattern recognition, usually a lot of experts, you just look at an OCT and you can already tell, okay, this must have an underlying inflammatory cause. And this for sure is not due to, for example, diabetic macular edema, where you have other additional underlying causes, which leads to the accumulation of fluid. And very, very often in inflammatory associated cystic macular edema, you will see the centrosymmetric macular edema. So you have the cysts kind of distributed very homogeneously right in the fovea. You very often see intact hyperreflective bands. So the ellipsoid zone and the ELM is very often, especially when compared to other underlying causes of macular edema, like in diabetes, is intact. And you very, very often see subretinal fluid. Also, the distribution, when you have a look at the EDTS grid, is very characteristic, kind of attributing to this fact. You see usually the cysts in the central millimeter and in the inner 3 millimeter in the EDTS grid, and usually the outer 3 millimeter are more commonly spared. When you use machine learning to differentiate whether it's a uveitis associated cystic macular edema, there are also the most three important factors or morphological parameters here: microfoci, the macular edema pattern. So like I previously said, this kind of symmetric distribution of the macular edema, and the foveal retinal nerve fiber layer thickening. And with these three parameters, you really have a very high prediction accuracy of these machine learning algorithms, like the basic one, in order to discriminate the underlying cause, and in this term, macular edema. When we look at the characteristic presentation on fluorescein angiography and also on fast OCT, you usually either see a petaloid pattern, also again very homogeneous, attributing to the fact that we have like these outer nuclear layer cysts centered symmetrically parafoveally. Or sometimes you could also see a honeycomb pattern, which is attributed to the fact that we have a lot of inner nuclear layer cysts being present in uveitic macular edema. Other patterns, like for example, a focal macular edema pattern, which is mainly due to leaking macroaneurysm, is very, very rare in uveitic associated cystic macular edema. In very inflamed eyes, or where you have eyes which have a long-standing history of macular edema due to uveitis, or a lot of inflammation, you may sometimes see this kind of diffuse pattern where you have like an underlying leakage of the posterior pole and also in the periphery. But like I said, if you have like a not so long-standing classic macular edema, it's usually presenting with a petaloid or honeycomb pattern in FA. We also know that there is a discrepancy between these two image modalities when we look for uveitis-associated cystic macular edema, and there's only a moderate agreement. And in 40% of the cases, you will appreciate macular edema due to uveitis in fluorescein angiography, but it won't be present in OCT, and vice versa. In 33% of the cases, you may see cystic spaces in OCT, but not in fluorescein angiography. And this is very interesting because it seems to have some clinical implication in terms of their prognostic value. Because there seems to be that if you see leakage on FA, but there is no macular edema present in terms of cystic spaces on OCT, there seems to be a longer disease duration. And also, if you have a discordant group, meaning that there is either macular edema present on OCT and not on FA, or vice versa, these kind of group of patients seems to show a less variable visual acuity improvement in terms of the improvement after treatment of the uveitis-associated cystic macular edema. And what is also interesting, that actually in uveitis-associated cystic macular edema, this discrepancy seems to be highest when you compare it to any other underlying diseases which can cause macular edema. For example, in retinal vein occlusion. So here, the concordance between these two image modalities are much better. When we have a look how macular edema in terms of uveitis resolves, develops, and relapses, there are also characteristic patterns. And it also seems that it's very unique to the inflammatory cystic pathway here. So usually here, for example, at baseline, you see a patient which has not been treated so far with uveitis-associated macular edema. And the picture in the middle, you see really 1 day after triamcinolone injection. And what you see is that initially the outer nuclear layer cysts seem to, or the cysts in the Henle layer seem to decrease and resolve, which is then followed by the inner nuclear layer cysts. And 1 week after the triamcinolone injection, you see that actually all the cysts are gone, but you still see some subretinal fluid being present. And then this subretinal fluid slowly decreases and resolves over time. While then after 2 months, or you see actually no no macular edema present, no subretinal fluid, and no inner retinal fluid being present. And this is in discrepancy to other diseases causing macular edema, because, for example, when we have a look at diabetic macular edema, and you, for example, treat it, no matter whether you treat it with steroids or with anti-VEGF, usually what you see is that the subretinal fluid is cleared first, and you still see remaining internuclear layer cysts. And then the cysts, the inner retinal layer fluid, is kind of lagging behind in terms of its resolution. Also, in terms of the new relapse or the new development of macular edema, it seems to be very, very characteristic. Here again, we see again after triamcinolone injection, the resolution of the outer nuclear layer cysts followed by the inner nuclear layer cysts, and 1 week thereafter, actually nearly no subretinal fluid and no cysts are present. And then in this case, for example, the patient showed a relapse 3 months after the triamcinolone injection. And what you see is that the cystic spaces and that the cystic macular edema starts in the inner nuclear layer and is then followed by the outer nuclear layer cysts. And again, this is in contrast to other diseases causing macular edema, for example, diabetic macular edema, where you usually see outer nuclear layer first and then inner nuclear layer second, because the pathomechanism is different. What is also important when we have a look at the morphological features, that usually the function is a little bit lacking behind the anatomical improvement. So for example, this was a small study where we looked prospectively on the microperimetry and the retinal sensitivity of the retinal sensitivity improvement of these patients. And what we saw is that the lowest amount of fluid averaged in uveitic macular edema was after 4 weeks of the treatment when we used intravitreal triamcinolone. However, the greatest retinal sensitivity improvement was actually found 3 months after the treatment. So you see the kind of functional improvement and the kind of recovery of the dysfunction and of the transmitter of the signals is just lagging behind a little bit. And also, when it comes to correlation of anatomy and function, we have to consider several points. You're all well aware that central retinal thickness is not the best way to do it. And usually, if you use it, the neuroretinal thickness is better than the whole retinal thickness, because it kind of excludes the subretinal space. And we know that subretinal fluid does not play a major role when it comes to a correlation of anatomy and function, at least not in uveitic associated cystic macular edema. However, other features matter a lot, and the ellipsoid zone integrity and the presence of a diffuse macular edema, and also the presence of ganglion cell layer cysts, because ganglion cell layer cysts only seem to develop in a degenerative way. So if you see them, it's barely that it's due to exudative forces; it's rather due to generative forces. So if you see them, usually there is they're lower or a worse visual acuity function, also worse retinal sensitivity. And of course, as Sapna has already mentioned it, drill is also very, very important parameter when it comes to the correlation of anatomy and functions. Parameters which don't matter is subretinal fluid, like I said, and also aberrant membrane. We know that aberrant membrane may play a role when it comes to recovery or the recurrence of macular edema. However, in terms of the pure correlation of anatomy and function, aberrant membrane does not seem to play a role, and also subretinal fluid has no direct correlation to visual acuity and retinal sensitivity. What are the prognostic biomarkers of uveitic associated macular edema? So when you have a look at the patient, when he comes in with a macular edema, what kind of anatomical features should you have a look at in order to get an idea how well the patient will respond, and also how likely it is that he will not show any recurrence, or he will show a complete resolution of the fluid. There are several parameters. One is the vitreomacular interface. One I've already mentioned, the ellipsoid zone integrity, the presence of subretinal fluid, and then again also drill again. So for example, we know that patients who have a PVD, a complete PVD, show the greatest decrease in central retinal thickness and also are less prone to develop a new recurrence when it comes to recurrence of uveitic-associated cystic macular edema. What we also know that the pre-treatment ellipsoid zone integrity plays a major role whether a patient will recover and gain significantly visual function when it comes to the resolution of fluid. And also the cystic spaces in the central millimeter is a good prognostic sign. Probably the reason for this is that if you have like the cystic symmetric macular edema right in the center, this can means of that the disease duration was not really very long and the patient is not kind of suffering from a long-standing recurrent macular edema with the presence of diffuse macular edema and already presence of intraretinal cytotoxic macular edema and a lot of degenerative changes. Another important parameter is the absence of an aberrant membrane, because when you have aberrant membrane, this means that the patients are more likely to show recurrence of macular edema and presence of subretinal fluid. These kind of, in terms of subretinal fluid, there had been heterogeneous findings in the literature. However, especially more recent papers really showed that there seems to be a beneficial effect when subretinal fluid is present. And with that, I would really like to thank you for your attention, and I'm looking forward to the next upcoming presentations and to the future questions from you. Thank you.
Thank you very much, Marion. That was wonderful. A very extensive overview of imaging. And with this, we now move on to the next topic of the webinar today on treatment options in uveitic macular edema. And for this, we have Dr. John Kempen, who needs no introduction, who is world-renowned in uveitis and for ophthalmic epidemiology, and he has provided several clinical trials. And at present, he's leading organizational projects in Ethiopia. And Dr. Kempen is also the chair of the education committee of the IUSG. Over to you, Dr. John.
Thank you kindly, and it's a pleasure to join everyone today. I'm going to focus on local treatment since Mark is going to do systemic treatment later. These are my, let me try to share again. These are my disclosures. So just making an overview of the talk, local therapies can include topical therapies for macular edema, periocular injections, intravitreous injections, suprachoroidal injections, and intravitreous implants. So topical therapy in general is limited because of the long distance from the ocular surface to the macula. And it's interesting to remember that it's a short distance to the sites where steroids will cause side effects. So it's generally not ideal. It may work better in pseudophakic eyes, and there's a risk of corticosteroid-related side effects if you treat with corticosteroids. Topical nonsteroidal anti-inflammatory drugs are sometimes discussed. There's strong evidence that this somewhat reduces the incidence and possibly helps with the resolution of post-cataract surgery macular edema. But uveitic and pseudophakic macular edema have different cytokine profiles, like Dr. Gangaputra was discussing, or she was discussing the uniqueness of it in uveitic macular edema. These might have a modest effect on uveitic macular edema, but it's not very clear. There are minimal side effects, and so sometimes it can be worth a try. And these are some of the example agents that might be used, usually 3 times a day. Topical difluprednate suspension also has been reported as a fairly effective way of clearing uveitic macular edema. This is basically prednisolone acetate, 1% that's been, or prednisolone acetate that's been fluorinated, which makes it much more potent, and it seems to be stronger, although it's only formally been proven to be non-inferior in terms of treating active uveitis. From the Proctor group, among 72 eyes, there was a significantly better improvement in macular thickness with difluprednate, a better improvement, or better improvement of the overall macular edema, better resolution, but then 11% had high intraocular pressure and 19% had cataract. So it seems to be effective in many cases, but might have side effects. Moving on to injectable treatments. One of the main disadvantages of these is that they wear off at an unpredictable time for things that are longer lasting, but it could include periocular injection, intravitreous injections of corticosteroids, VEGF agents, and possibly methotrexate, suprachoroidal injection of corticosteroids, and corticosteroid implants. So triamcinolone acetonide, 40 milligrams per milliliter, is usually the agent that is used. Part of the rationale is that if you accidentally injected it into the vitreous, it's not necessarily toxic, and indeed is used intentionally for that, as you'll see in a moment. And this is just showing a diagram of different places periocularly you might inject. So typically it's done either in the subtenon space or in the orbital floor. Most people will inject superiorly into the subtenon space because you'll miss this inferior oblique muscle. And so those are the two main approaches. Usually this is just done once these days, although it used to be said that you should do it 3 times before moving on to something else. Relative contraindications are scleritis, people who are steroid responders, and then all of these steroids that would fit into that category. But we should remember that it's not really dichotomous whether someone's a steroid responder or not, and people can have a steroid response after years of treatment without having intraocular pressure elevation. Also, this probably increases the risk of cataract. In one of the site papers Nita Shen had that she had led, we found that visual acuity improvement happened in about 50%. So that's sort of what we looked at mostly for improvement of macular edema and sight, because a lot of it was pre-imaging. And then there were a number of side effects as well with this kind of approach, perhaps more cataracts than they really were, because sometimes this treatment would be given to prepare for cataract surgery for a cataract that was already present, and we couldn't discriminate that. I'm going to come back to the outcomes of that when we get to trials. Intraocular therapy is also efficient for providing local drug delivery with minimal systemic side effects, and is highly potent, but causes even more local side effects, or so it seems to me. And the cataract risk can be quite high, and there's a rather small endophthalmitis risk. As with the other injections, it's less efficient for chronic disease. So if you have like a chronic macular edema that recurs when the treatment wears off, then you'll constantly be having to chase it with this local approach. Commercially available triamcinolone acetonide with the Western brand name Kinalog has an alcohol preservative that's likely to become toxic with multiple repeated use. And so there's a preservative-free version now available, although we seem to have shortages of that from time to time, and this isn't available worldwide. The typical intravitreous dose is 4 milligrams per 0.1 milliliters, so it would be 40 milligrams and 1.0 milliliters for the periocular. But I've often wondered if lower doses might have a more favorable risk-benefit ratio, like what was seen in the SCORE trial for vein occlusion. So the preserved one is cheaper, and the preservative-free is relatively expensive, although quite a bit less than implants. So this was sort of one of the brilliant instances of getting a drug approved, where they were able to say that this is an approved drug, and we just have to do a safety analysis for intravitreous use, and it was approved faster than anything I've ever heard of. And so they had a small study to get this approved, and they did see elevated intraocular pressure, and this tended to resolve with IOP-lowering therapy, and they didn't really have enough follow-up to look at cataract. So we'll get back to more outcomes of this with the trial later. Suprachoroidal injection is a newer concept that was developed by Hank Edelhauser, a longtime basic scientist at Emory. And the theory is to use a microneedle to direct medicine into the suprachoroidal space. And they say that when you inject it this way, it tends to go posteriorly and not anteriorly. And so this might protect it from getting into the trabecular meshwork in the lens. At least that's the theory. And this has been evaluated in FDA drug licensing studies formally, and is now FDA approved as Xipere. I've never really known how to pronounce that, since we don't have it in Ethiopia, where I'm mostly practicing now. So there was a sham-controlled randomized trial and then an open-label trial. In one of their papers, they combined these. The eyes had to have uveitic macular edema with central subfield thickness more than 300 microns and an ETDRS visual acuity that was reduced but not nothing. And then for the open label, it was just some visual acuity. And for the randomized trial, they allowed a moderate amount of prednisolone and immunosuppression if no escalation was planned, and they could have up to 2 intraocular pressure lowering eye drops. And they were primarily looking at improvement of 3 lines of visual acuity, 15 letters on an ETDRS chart, which is the FDA's favorite outcome and is a good outcome to consider for uveitic macular edema because often vision improves a lot. And they also, of course, looked at adverse events. And this is one of the outcome figures. So this is looking at the number of letters of improvement in the active treatment and sham group. So there was a 10-letter difference or 11-letter difference, which is about 2 lines. It's 5 letters per line. So a pretty impressive difference. And looking at the ones that had reduced thickness by sort of getting close to the normal range, it was around 60%, about 90% had a 29% improvement. You see just a few in the placebo group that accomplished that. So it looked pretty impressive. In terms of adverse events, there weren't really a lot of impressive adverse events. In particular, the elevated intraocular pressure didn't seem to be more in the study, not of a huge number of eyes, but a pretty good number. Cataract also didn't look too different. And so this was, to me, looks like an encouraging result. Moving on to implants, shorter acting implants, in my mind, theoretically probably have similar side effects and problems to triamcinolone acetonide injections. We'll see that when we get to the POINT trial. But the dexamethasone implant that was developed was argued to have less of that, maybe because the pellet goes further back into the eye and away from those sensitive structures. And then the long-acting fluocinolone acetonide implant that was studied in the MUST trial has really a lot of side effects, but we'll go over the benefits that it has. So this is just describing the Ozurdex implant, which is sort of like a vicryl suture with steroid impregnated into it, and it gradually dissolves after it's injected. It disappears within about a month, but it's supposed to last for several months, but certainly not longer than 6 months and probably less than that. And so this is showing the delivery advice. It's sort of a pleasing kind of delivery device, and you can inject it as an office procedure by putting it in at 45 degrees halfway through and then rotating it to 90 degrees and shooting it through the pars plana. The long-acting implant, it has to be surgically implanted, and it has this little hole built into it that you can hang a completely non-dissolving suture through, that you actually suture it to the wall of the eye. And this is just showing Glenn Jaffe, who was very involved in the development of this, putting one in. And so you suture it like this. It actually sort of gets imbricated here rather than just loose like it looks in the diagram. And you can see with this is a ganciclovir implant, but it's a similar kind of thing. You can see it actually is held by the wall of the eye. And Perlene suture is recommended because the nylon suture originally used can, especially for the one that's going to hold it in place, can eventually dissolve. In the MUST trial, we looked at macular edema among many other things, and you can see that after 6 months, the implant versus the systemic therapy, so this was a local versus systemic therapy trial, was significantly better in terms of macular edema, and these systemic ones could get injections and typically did. But the difference kind of waned over time, mostly because the systemic was getting better. But it looks like that this was maintained, but still only about half resolving. This was a very severe group of patients. And then after they were so many side effects with that one, a sort of lower dose fluocinolone acetonide implant that was injectable was developed, which is sort of like a straw with the fluocinolone acetonide in it. This is a very insoluble steroid, and so a very small amount of it can last a long time. And it has this injection device. And so this also has a drug licensing randomized trial. And you can see that for macular edema, which was not the main focus of the trial, this is from one of the supplementary documents, it does seem to get better in terms of thickness. And then the other side catches up, probably because doctors figure out some way to make it get better. I don't know if this was statistically significantly different. It sort of wasn't a big focus of the study. And this was the distribution of vision. And so you see with the active treatment, it sort of shifted somewhat to the right, which is the improved vision, although most of the others improved too. So in terms of the side effects, intraocular pressure elevation is more common with the YUTIQ than with sham, and cataract is fairly common with this, and so it is less than what we were seeing with the Retisert implant, but it's still pretty substantial. All right, moving on to trials then. NEI has recently begun funding trials about uveitic macular edema, and the MUST group went on to do a set of studies called MetaMUST, and I'm going to try to quickly go through these. Jennifer Thorne was the protocol chair for the POINT trial, and this was a trial that was comparing intravitreous triamcinolone versus periocular triamcinolone versus Ozurdex, so a three-way clinical trial. And it was thought that periocular would be less effective, and that Ozurdex would be non-inferior and have less side effects as the hypothesis. So that's not exactly how it turned out. So this was a multi-center randomized trial, and the main outcome was thinning back towards normal as assessed by OCT, and then other outcomes. And the division of patients was fairly similar in the two groups, a few differences that probably aren't important. And the patients typically got the assigned treatments. They didn't have to keep getting treatments if they were improved. And so when we see then compared to baseline with each kind of treatment, all of the treatments showed improvement, as you might imagine. But the smaller the fraction or decimal here, the better the improvement was. So it tended to be less with periocular. And when you do the comparison, indeed, you see that intravitreous was superior to periocular, and so was the Ozurdex superior to periocular. And then in terms of non-inferiority of dexamethasone with respect to intravitreous triamcinolone acetonide, this also was established. This is sort of the percent that had a 20%, or proportion that had 20% improvement from baseline, which earlier studies from MUST had suggested was a visually important threshold. And so you can see that with the intravitreous injection and the dexamethasone in green, that it sort of quickly improved, whereas the periocular sort of gradually improved. And this sort of corresponded to a period of time where there were a lot of crossover treatments into one of the others. And so it appeared that although they all helped, that this one didn't help as much. And the narrowing is really from crossovers probably. And when we look at resolution, it's sort of a similar but less compressed pattern. When we look, let me just skip over this one. When we look at the side effects then, in terms of intraocular pressure, these are occurring somewhat more in the ones that were superior, so maybe just reflecting potency. And when we look at the dexamethasone compared to periocular, it's significantly more with two of the intraocular pressure outcomes, and it's tending that way with the intravitreous triamcinolone versus periocular as well, whereas these two are more similar. If we look at people that required treatment, it's sort of pretty overlapping in the three groups. And so the conclusions of this trial then is that intravitreous triamcinolone acetonide is superior to periocular triamcinolone acetonide for treating uveitic macular edema, that intravitreous Ozurdex also is superior to periocular triamcinolone for treating uveitic macular edema, and that the Ozurdex is non-inferior to the intravitreous triamcinolone acetonide. So all of those were established, but the Ozurdex was not associated with a lower incidence of elevated intraocular pressure than the intravitreous. If anything, it was slightly more. I'd like to point out too, this is only 6 months follow-up. so getting out to 24 months. So probably cataract risk is not very well assessed in this, and it could be more with the intraocular treatments. So just like to acknowledge the group. And then there's also been the MERIT trial, and unfortunately I can't present the primary results of it because they're being announced next week, so it's under embargo. But this is a study that wanted to look about whether intravitreal methotrexate and ranibizumab could be considered as alternatives to steroid injections, because people worry about the long-term effects of repeated steroid injections. So this was a trial then where we enrolled people that had recurrent uveitic macular edema to the 3 arms. And it's sort of a typical multi-center randomized trial, again, 1:1:1, like the point. The difference, though, is it's recurrent, not the other one could be either primary or recurrent. And, some stratification variables in the primary outcome at 12 weeks. And so I'll have to leave it to you to check on the results that are going to be announced in about a week from now. So although those of you that attended the Uveitis Subspecialty Day last time might have heard them, but it's supposed to be embargoed now. Thank you very much, and I'll stop there.
Thank you, John.
So moving on to my MC role, our next speaker is Professor Rubens Belfort. So we're really honored to have Professor Belfort with us. He is one of the most famous uveitis specialists in the world. He has served as the lead professor at the Federal University of Sao Paulo in Brazil for many, many years, I think more than 3 decades. And he also has directed the Philanthropic Vision Institute and has been president of the Brazilian Academy of Ophthalmology, as well as having been president of the Pan American Congress of Ophthalmology, editor of important journals, and chair of many organizations. And his scientific contributions are extremely prolific, with several hundred peer-reviewed articles and a great deal of experience with toxoplasmosis, retinitis, but also with many other things. He's given the Jackson Memorial Lecture and many other named lectures, and we're very happy to have him presenting to us today about managing macular edema and infectious uveitis. Thank you very much, Professor Belfort.
Thank you so much, John. Can you see my slide here?
Yes.
Good, good. Well, thank you so much for this. It's a great session. Congratulations to the organizers. John, I believe, just gave an idea of my age with this presentation. Yeah, I'm over 50 years in the field. And I want to present here some of my personal concepts about the treatment of macular edema in infectious uveitis. And I want to point out that my father was ophthalmologist, and I remember when he told me that in the 50s, experts in uveitis would get together and analyzing the shape and the number of posterior synechia would try to understand the etiology and also the future of the patient's uveitis. So sometimes we pay too much attention to the morphological changes, and it's not necessarily helpful for us to understand what the best treatments and what happens with the disease. So I'm gonna talk with you about the treatment of macular edema in infectious uveitis, and knowing that, of course. Okay, let's see what happens here. Okay, it's not moving, so. Okay, knowing that we will have excellent presentations, I'm going to try not to repeat what was expected would be discussed. And I'd like to point out some generic aspects first. We talk about infectious uveitis, but we know that infection is a very complicated term. We have learned a lot recently about COVID, about the long-term COVID and post-acute infection disease. But we know that this happens very often in many, many other diseases, toxoplasmosis, herpes, tuberculosis, so many. The point is, yes, we may start with infectious uveitis, but the infection may go away, but the disease stays. And talking about an infectious uveitis not necessarily mean that the infectious agent is there. I think that we have learned a lot about tuberculosis in the last years, and the Indian experience, as in many other countries, has shown us how important it is to try to understand better what is the limit of the infection causing the disease. We know also that we may help the patient with an anti-infectious disease, and they maybe should be used longer if we have to use steroids and other anti-inflammatory agents. We do not know, though, for how long we should use this patient, how safe it is to treat the macular edema in these patients with drugs that would interfere also with anti-infectious mechanisms. We talk also about active infections, but, well, the patient may have an active infection that is not related to the eye, and getting the information from other parts of the body may not really help us to differentiate with the patient that we are lower or higher risk of receiving medication. And why I'm saying that? Well, because John just gave an excellent presentation, but basically we know that steroid is our main piece, our main bullet to control the disease. And also, when we talk about the infection, please do not forget that we still rely on the response of the organism, the clinical picture. Most of the times, we're not sure at the time we make the diagnosis if the infectious agent is still present in the eye and in the body. Yes, of course, more precise and much faster results are happening. We have panmicrobial and by bacterial, viral, and fungi kits, and we have used it. It has helped a lot. We do more and more intravitreal sampling, and also get the aqueous humor material for analysis. And this, I believe, is going to get more and more useful for us as uveitis experts, trying to differentiate, compare, and analyze the eye response to extraocular response. It's been also very well presented, the pathophysiology of the macular edema in uveitis, the fact that they will have leakage, fluid, and swelling. But second to that, we have very often what you would call generically as cystic degeneration of the macula, as well as epiretinal membrane, vitreoretinal tractions, and finally macular atrophy that could, in many situations, especially for not well experienced ophthalmologists, to misinterpret what happens in the eye as a macular edema, and they are not anymore. So this is a typical old example of macular change appreciated by OCT, and patients in where probably our treatment would work very well. Different from those patients that have been treated as macular edema with systemic and intravitreal medications, but we know that at the time they would not respond to the treatment. Other examples show the importance of epiretinal and other vitreoretinal membranes that very often interfere with vision, avoid or decrease the action of anti-inflammatory drugs such as steroids, and point out the importance of doing surgery in some of the patients. Causes of the conditions and related leakage are very important to be understood. And also remember that very often the macular edema is secondary to what happens in other parts of the retina. Yes, and I believe that would be always important in case of this infectious uveitis to control the infection and also the inflammation. We know that very often the macular edema disappears with the control of the infection in the eye, in other parts of the retina. And most important example is toxoplasmosis, in which patients can develop macular edema. You treat the active uveitis by toxo, and the patient gets better. Even some cases of new vascular membrane do not need to receive specific treatment because they go away, especially in young patients with the treatment of the infection. As I said, I believe that vitrectomy is very, very important. probably we should use it more, especially in patients where you do not appreciate well the change in the retina, and vitrectomy and the removal of the vitreoretinal membrane, the pulling of the retina, and also the removal of the inflammatory agent in the vitreous can help a lot in the control of macular edema in these patients. Often not common, but we see in some patients with infectious uveitis, some occlusive vasculitis, and laser may also have a place in the treatment. Intravitreal anti-VEGF is being used in uveitis. Our experience is that it is not as useful as steroids, and in most of the case, it does not give the therapeutic result that we would need. John has also discussed it very well, the role of non-steroidal anti-inflammatory or dozolamide drops, as well as oral acetazolamide. We do not have a good experience with that. And in most of the cases, we do not use anymore. In my country, these are expensive drugs, and most of the times are useless. Intravitreal or periocular steroids also been very well covered by John. I fully agree with everything he said. In these cases, what I'm discussing now, of course, would be very important to do as much as possible an antimicrobial coverage if we have to use steroids in these patients. It is no doubt an unmet need. And now we're doing more and more biologics. I believe that we're gonna revisit the potential action of methotrexate inside the eye, as well as other old drugs and new ones also. I believe that biologics through local action in the eye will be something very, very useful in the future. John and I did not prepare together this talk, but this is also my point. I believe that Ozurdex is a very sad example of ophthalmology based on dollars and not in evidence or even in assumptions. It's more than 100 times more expensive than triamcinolone. We have had triamcinolone without preservative in Brazil for over 15 years, and we have used it more and more with excellent results. As well as John said, we also been exploring the possibility of using triamcinolone in much lower doses and getting less side effects. Of course, we do not use these drugs in case of active infectious uveitis, such as toxoplasmosis or herpes, but in many other uveitis considered as infectious, especially the ones usually diagnosed as associated to tuberculosis, we have to use something to control the macular edema and improve the vision. And then triamcinolone in small doses in patients with coverage of anti-tuberculosis treatments are used. In Brazil, you may have up to 10% of the population with positive results for tuberculosis, and it's much more difficult to analyze this potential infectious disease as in other countries. Also, just to show here, we probably do not need some strong dose of triamcinolone inside the eye to get a better result. And we hope that in next year, we're going to have a paper showing this. Well, last point I'd like to comment is, of course, interleukins. Of course, interleukins is contraindicated in infectious uveitis, but again, goes back to my first slide. What is really infectious uveitis? I'm not talking of herpes. I'm not talking of CMV. I'm not talking of toxoplasmosis, but I'm talking of these all others that we call it sometimes infectious, and they are not more infectious, or maybe they have never been infectious. And I believe that anti-IL-6 that has been now tried for non-infectious uveitis may be used also in other situations. And I hope that this will be explored well, and we may have in the next future more potent agents that would be used in the eye and would control the immune reactions related to uveitis. Of course, everything can be a Pandora box, but I do not expect to find just bad things when I open a Pandora box. I hope that in this case, we're going to have good information for the next years. Again, thank you so much for this invitation and the possibility of participate in this symposium. Thank you, John, and all the other organizers.
Thank you, Dr. Belfort. That was interesting and a very not so commonly touched topic of macular edema and infectious uveitis. All the time we hear is of autoimmune uveitis. So thank you very much for providing this information. And we now move on to the next topic of the webinar, which is effect of systemic therapy on uveitic macular edema. And for this, we have Mark T. Smith. He has been on the board of IUSG for a long time and doing wonderful work for IUSG and currently the secretary of IUSG. Dr. Mark T. Smith is also the director of MIOS Microinvasive Ocular Surgery Clinic in Lausanne, Switzerland. Over to you, Mark.
Hi, Rubens and John. It's always a pleasure. So yes, I've been tasked to talk to you about the effect of systemic therapy on UME. And you've already had wonderful talks, and I'd like to take maybe one message out of what John said. He showed you that in some cases, systemic therapy, local therapy, although it's very effective at getting rid of edema, in the long run causes a lot of side effects at the level of the eye. By opposition, if we're going to use systemic therapy, it may give you some good results, and this is what I'll discuss, but you have to be able to monitor systemically the patient with blood tests, be able to see a patient on a regular basis, or otherwise have an internist who will be able to do that for you. That's in a certain way a synopsis of what we'll be discussing now. But there are two aspects, because one is the treatment with systemic medication, and the other is that certain systemic therapies can cause macular edema and uveitis. And so I'll elaborate a little bit about that at the very end. I'll go back to the MUST trial, and for, I guess most of us, we know that the MUST trial essentially compared the injection of an implant inside the eye with systemic therapy. A systemic therapy that was following more or less the guidelines that had been established in 2000. That is, we usually start with corticosteroids at 1 milligram per kilogram up to 60 milligrams, and after a few months try to taper so that we get to a low dose of steroids. And if that doesn't work, a secondary immunosuppressive agent is added. If you look here at more or less the results with implant versus systemic, you can see in this in these two second and third column, the results essentially are maybe there is in fact no difference once you get to about 24 months with regards to edema, maybe a slightly better effect with the use of systemic medications for certain things. But at 2 years, if we look at the systemic arm, 65% of the eyes had improved edema, and about half of them had complete resolution. And by complete resolution, on the OCT or on the fluorescein, there had been disappearance of edema. So systemic therapy works, at least according to the basic premises, but it's not a complete panacea. And just as a recollection here, this is more or less the scheme that had been proposed in 2000. So for about 4 weeks to about 3 months, we tried to treat with fairly high dose corticosteroids. We then, over the ensuing 2 to 4 months, tried to reduce the dose to 10 milligrams or less of prednisone. Today, we'd probably suggest that it be under 7.5 milligrams. If at any point there's a recurrence, you add in an immunosuppressive agent, or if you're not able to control very well the disease, that's what you would do. And if you had a recurrence, then you would start over again. So among the immunosuppressive agents that we could consider for this type of treatment, the two that are frequently mentioned today, at least, would be methotrexate systemically or mycophenolate. You've heard that methotrexate can be used locally. With the dose of methotrexate systemically, In this particular studies, patients were started on 15 milligrams every week in association with, of course, leucovorin for a number of days, 5 out of 7 following the methotrexate dose. And then after 2 weeks, it was increased to 25 milligrams, which is a little bit higher than what I think many people use when they're using methotrexate. Mycophenolate was started twice a week, twice a day with 500 milligrams, and then after 2 weeks was increased to the typical dose, which is 1.5 grams twice a day. This was for patients with active disease, and they were all started on steroids in this particular study at 1 milligram per kilogram or 60 milligrams per day, and tapered as proposed in the guidelines. And the interesting thing is that if you look at the results at 6 months and at 12 months, we find that by 12 months, there isn't really much difference between the two groups. And yet in the minds of many people, methotrexate is a drug that takes time to work and it's less effective. Mycophenolate, by the way, will take about 8 weeks to really give you an effect. So you don't have to expect too many changes early on. But you'll see that the reduction in central macular thickness does not give you a significant p-value between the two groups at 6 months or 12 months. If they had not really responded by 6 months, they were then switched over to the other medication. And so if we look at improvement, for example, here in terms of the macular edema, again, there isn't really much difference between the two groups. So it's a question of choice and preference. It depends on the side effects that the patients may have with one drug or the other in terms of what can be used and given, and also their ability to be able to follow a regimen, with example, with methotrexate, that is maybe a little bit more complicated. A treatment which is not very much talked about nowadays, particularly in the very acute phase of uveitis, is the use of intravenous methylprednisolone. This is a fairly recent study done in Spain, and what it shows you is that if you're giving a pulse, which can be from anywhere from 80 milligrams to 1,000 milligrams, 1 gram IV with methylprednisolone, the dosage depends on the age of the patient. In their particular studies, they even had some children that were involved. It is usually infused over an hour. You need to follow the patient carefully, and particularly their electrolyte balance, potassium in particular. And it's usually repeated 2 to 5 times, given once a day. You can see here that in this particular study, there were patients that had panuveitis, posterior uveitis, anterior uveitis. They had multiple medications that were being used in terms of immunosuppressives or even biologic agents. And what you see is that with the pulse treatment in these patients with active disease, there is a very rapid improvement in terms of the vision as well as reduction in OCT thickness. So that is in fact a good way to be able to check whether a patient still has active uveitis that is responsive. But overall, over time, they do require a continuation with other medications, which could be steroids or more likely a shift in the concentration of the immunomodulating agents that they're receiving. But you'll notice here that in this population using intravenous methylprednisolone, 38 of the 50 patients that had edema at the start of their study were edema-free. Now, part of the reason for this is that very often this treatment is used in patients that have very active new onset uveitis. While some of the studies we talked at before, very early on, where we had only 50% success, are patients that have very often chronic disease and cystoid macular edema. And if there's a lot of structural change, which was alluded to earlier, the probability of having some degree of improvement becomes much less. And I'll come back to that later, because there are patients that present to us that have more or less burnt out uveitis and have cystoid macular edema that is present. And those patients can still benefit from having a reduction in the edema, but the approach has to be somewhat different. Now, biologics, of course, are being used on a regular basis. With regards to the anti-TNF, adalimumab, and now some of the analogs are being used. And in this particular study, 40 patients with refractory uveitis had macular edema out of a group of 131. And at 6 months, with a dose of 40 milligrams sub-Q every 2 weeks that was held for those six-month period, 28% were able to resolve their edema. Now, the patients were followed longer, and over about a year to 18 months, 50% of these patients could in fact stop the treatment and have no recurrence of the edema in the following 6 months to a year. This study compared adalimumab with infliximab, and what we find here is that if you look at the biotherapy with regards to clinical response, you find that there is maybe a slight benefit for adalimumab, but not much difference with regards to infliximab. However, with regards to the relapse rate, it's better with adalimumab. And there are other studies that sort of contradict this. It may have to do with the ability to be able to administer the drug. Infliximab is often given IV and so requires admission, while adalimumab can be self-administered, and the dosage can be adequately modified as necessary. The other is, of course, that adalimumab is a fully humanized antibody, so there's less risk that you'll start developing some antibodies, which can happen with infliximab, and that really wasn't looked at in this particular study. Now, Rubens alluded to the use of anti-IL-6 as being an approach, and yes, tolicizumab and the other anti-IL-6s seem to work quite well. If anything, they're better at resolving macular edema than anti-TNF agents. The dose is also given either IV or sub-Q. The dosage for sub-Q is 132, if I recall well, micrograms. It's given every 4 to 8 weeks, and it will progressively lead to a reduction of edema, irrespective of the type of disease present. And the side effect profile is in fact quite good with regards to anti-IL-6, maybe even better than what we're able to see with the use of anti-TNF. And here again, a comparison now between anti-TNF versus anti-IL-6 in uveitic macular edema. And this does favor quite favorably tocilizumab over anti-TNF with regards to the response of the CME. And with regards to the rate of relapse, there isn't really much difference between the two. Again, maybe slightly better with regards to tocilizumab as compared to the anti-TNF. And if you look at, for example, adalimumab versus infliximab, there isn't really much difference. Intravenous versus sub-Q for tocilizumab, again, not very much a great difference between the two. Now, if we're going to talk about systemic therapy, we've got to talk about the interferons. And this study now is a little bit older by Mackison. She looked at comparing methotrexate given subcutaneously versus interferon beta. And what we see is that in those that were started on interferon, there is a significant improvement in vision fairly quickly within about 3 months. Quite a significant number edema disappeared. While with the methotrexate, there was improvement, but they did better once a switch was made over to the use of interferon, which is given subcutaneously 3 times a week, starting with a lower dose, which is then increased to 22 to 44 micrograms. And with regards to the side effect, the major one was really flu-like symptoms. It's usually in the first 2 to 3 weeks of treatment. It can also be helped by using the use of paracetamol or Tylenol. And the other symptoms are somewhat less. With regards to interferon beta, there are less patients that develop depression, which is a problem with the use of interferon 2 alpha, where the results are in fact quite good also. UME was controlled in this study in 34 of 38 patients treated, but you had to watch for neutropenia, thrombocytopenia, the flu-like symptoms, and the depression doesn't necessarily follow with the flu-like symptoms. It can in fact be independent. Again, you start with half the dose for about 2 to 3 weeks, and then you move up to 6 million units sub-Q 3 times a week. Now, just as an aside, biologics can sometimes cause macular edema, and so if you're going to use rituximab, it may be something to remember. The rituximab in this case was continued. The patient just had a little bit more steroids to try and control the edema. So idiosyncratic responses with the use of biologic agents are possible. So if the response isn't what you expect, then consider that maybe it's a side effect. This may be useful. I look at it as a checklist on how to choose a therapy. And the first is the inflammation still active? As I've mentioned earlier, in late stages, there is a poor functioning RPE pump and Mueller cells are dying off, so that you may have structural changes that won't respond to edema and are not related to inflammation. Now, you've heard a very nice talk by Marian with regards to macular morphology, and that should give you an idea whether improvement is possible. In late stages, if we're going to give treatment, we should have a treatment that is not going to cause too many side effects, and we should give ourselves limits as to how long we want to treat systemically or locally. If one eye is involved, it's often much easier to try and use local therapy rather than systemic therapy. And if we do have asymmetric disease in the two eyes, then the aim should be to control the less affected eye systemically, since it'll have an effect on the other eye, and then potentially combine with local therapy in order to achieve the best possible result in both. Of course, if there are no side effects in the patients and monitoring is easy, then obviously you could increase the systemic dose. Prior or current response to treatment in ME is important, so find out what they've had in the past, and of course consider comorbidities that are either local or systemic. If there's glaucoma, if they have a cataract, diabetes, and mental state, as we've just heard with regards to interferon, is an important element. ME doesn't come on its own. It's usually associated with a lot of other things. And as for diabetes and other diseases, how likely is the patient to show up and be followed? It's easier to treat locally than to have to coordinate the monitoring of systemic disease. And if they have a steroid responder, or if they have a cataract, or can we implant, in fact, an IOL in this patient, or will they develop many synechiae? If they will, then maybe using something else than trying to find an alternative treatment that reduces systemically the uveitis may be useful. What about RPE dysfunction? Well, acetazolamide was considered years ago. It doesn't work all that well. It reduces the edema, but it doesn't necessarily lead to improvement in vision. But these were patients with very chronic disease. More interesting is the growth hormone analog, and we have 5 different receptors. They're present in the RPE, and if you stimulate them, you're in fact able to stimulate the RPE pump. And so these were patients that had macular edema due to uveitis on a chronic basis. And you can see that with the start of octreotide, the growth hormone analog, the CME disappeared. With the stop of the octreotide, the vision got worse. Now, these were chronic patients. Vision was not much improved here. There is some other studies that were done in Boston that gave much better results in terms of improvement. I've used it too, using lanreotide, which is another analog, and with good results. It's given subcutaneously, but unfortunately is fairly expensive. So just to finish very quickly, uveitis is associated with end macular edema with particularly drugs used in cancer. This is an estrogen receptor analog that causes macular edema. These edemas are usually mild, and the inflammation in particular is mild, and they usually resolve either with topical steroids or with the use of systemic steroids. And this is true also for checkpoint inhibitors, where they don't occur immediately, can occur after the 3rd or more injections. With the checkpoints, it's usually associated with the granulomatous type of uveitis, and it responds to oral steroids, as is shown here. And I'd like to just present this case. This was a chronic lymphoid leukemia patient of mine that was operated for cataract. 12 months later, when you really would expect not to see any more edema on the basis of a Irvin gas, everything went perfectly well for the surgery. He developed edema in this eye. He had the peel in the other eye, had edema there too. And what was unbeknownst to me, apart from this slight inflammation in the anterior chamber, was that he had been placed on a Burton kinase inhibitor, and this is associated with uveitis and the development of macular edema. And so in the course of the follow-up, which was years in this patient, I wasn't really informed by his oncologist, and this was the cause of the edema, which was controlled with a very low dose of systemic steroids. So systemic management of UME is certainly possible. It's effective. It avoids a lot of the local side effects that have been described. It just requires a bit more follow-up systemically and occasionally more problems with regards to, for example, local infections. And do remember that macular edema and uveitis can arise from systemic therapy. So do complete your list of medications and occasionally check them again, because you may be surprised by what patients are taking and not telling you. Thank you.
Thank you kindly, Mark. So that was great. And yeah, systemic, I think, has a lot to recommend it, although it may not always work, but none of the treatments may always work. So we sometimes have to try different ones. So our last talk, we're privileged to have Professor Rima Bansal, who is our Secretary of the Education Committee for IUSG. She is extremely prolific in publishing about our field, and especially brings special knowledge at the interface from vitreoretinal surgery and uveitis, and has been many years serving at the Postgraduate Institute of Medical Education and Research in Chandigarh, India. Thank you so much, Rima, and we look forward to your talk.
Thank you, John. So I shall be talking on the role of pars plana vitrectomy for treating uveitis macular edema. So uveitis macular edema remains an unsolved problem because of several reasons, like we have limited understanding of its pathogenesis, and I'm glad we heard Dr. Sapna today, who elaborated so nicely on the pathogenesis. Also for the reason that we have varying and diverse etiologies of uveitic macular edema, and whatever evidence we have so far is largely based on the retrospective studies. And of course, this macular edema has been reported in different stages of evolution of the disease, and with lack of randomized clinical trials which compare different forms of therapy for uveitic macular edema. So all these factors lead to an unsolved problem of uveitis macular edema. And if we come to the pars plana vitrectomy in uveitis, its therapeutic role was first demonstrated in 1979 by Diamond and Kaplan, who showed that it caused improved visual outcome following vitrectomy and lensectomy in patients with uveitis. And they postulated that removing the vitreous gel alone was therapeutic enough in uveitis. Now, from our experience based on the microincision vitreous surgery in uveitis, we found that it leads to definitely visual improvement in these patients, also leads to decrease in inflammatory activity, leads to an early discontinuation of steroid therapy, and decreased use of immunosuppressive therapy. But when it comes to macular edema, we really don't have any answer. And with this, I would first like to give a brief perspective from the vitrectomy of phakic cystoid macular edema study that was published in 1985, where they found a statistically significant improvement in visual acuity in patients who underwent vitrectomy surgery for chronic CME after cataract extraction. And they found that since there is some evidence that CD5 plus B lymphocytes and TCR gamma delta T cells are present in the vitreous in some cases of autoimmune uveitis, so these cells are implicated in perpetuating the autoimmune inflammation, perhaps by continually presenting the antigen despite inadequate immunosuppression. So I'll take you through a couple of studies that evolved concerning the uveitic macular edema and vitrectomy. So this was way back in 2001, where the authors conducted a retrospective study on pars plana vitrectomy for CME secondary to the sarcoid uveitis. This was from the Kyoto University Hospital in Japan. The report was on 14 subjects, 18 eyes of cystoid macular edema and sarcoid uveitis that was resistant to the medical therapy. All eyes underwent pars plana vitrectomy. Of this, 9 additionally underwent ERM peeling or posterior vitreous cortical removal. Now, the vision assessment at 12 months showed that 10 eyes, that is 56% eyes, improved by more than 2 lines, and 6 eyes, that is 1/3, remained unchanged, and 2 eyes worsened. Concerning the cystoid macular edema. This was the slit lamp biomicroscopic examination of CME. It resolved in 14 eyes at 9 months post-operatively following vitrectomy. And 1 eye showed partial improvement and 3 eyes remained unchanged. The authors performed combined lensectomy vitrectomy in 8 eyes, as they believe that complete removal of the interior hyaloid gel may reduce post-operative cyclitic membrane formation, which can lead to tractional detachment of the peripheral retina and ciliary body. Following this came another study in 2004 on the visual outcome of patients undergoing vitrectomy and ICG-assisted ILM peeling. This was from Germany, a retrospective study again on 23 eyes which had persistent cystoid macular edema. All these eyes underwent vitrectomy with ICG-assisted ILM peeling. Now, these were different groups of CME secondary to uveitis in 9 eyes, CRVO in 4 eyes, diabetic retinopathy in 5 eyes, vitreomacular traction in 2, and post-cataract surgery in 3 eyes. 19 eyes underwent a tamponade either by gas or by air or by silicone oil, and none received tamponade in 4 eyes. The outcome of vision at 6 months was there was improvement in only 1/4 of the eyes out of 23 eyes, and this improvement was predominantly seen in the uveitis group, followed by the diabetic retinopathy group. However, there was no change in the vision in CRVO group, which had CME and underwent vitrectomy. So overall, a significant visual acuity improvement was observed in only 1/3 of all cases 12 months after ILM peeling for persistent macular edema. ILM peeling may reduce the intraretinal edema, but it does not affect the underlying mechanism causing the macular edema. Now, this was followed in 2006 by another study that is on the effect of PPV on CME associated with chronic uveitis. And now this was the randomized controlled pilot study that was published from the Moorfields Eye Hospital, London. This was a prospective interventional randomized controlled pilot study. 23 eyes with CME secondary to chronic intermediate or posterior uveitis, unresponsive to the medical treatment. They randomized the eyes into 2 groups, the surgical group, which had 12 eyes, and the medical group, which had 11 eyes. The surgical group underwent vitrectomy, and the medical group received systemic steroids with or without immunosuppressive treatment. The outcome measures were visual acuity and angiographic appearance of cystoid macular edema at 6 months. Now let's see in group S, which is the surgical group, the mean visual acuity improved significantly from baseline to the postoperative follow-up, whereas in medical group, the improvement in the mean visual acuity was only marginal and it was not statistically significant. Coming to the angiographic CME, 58% showed unchanged CME, 33% improved, and 1 eye worsened. When it came to the medical group, only 7 out of 11 cases had a good quality angiogram because these were not operated. The angiographic CME remained unchanged in majority of these 7 eyes, that is 4 eyes. It improved only in 1 eye and worsened in 2 eyes. So the authors concluded that PPV for CME secondary to chronic uveitis had a significant beneficial effect on visual function. However, angiographic improvement was seen in only 1/3 of the patients. So visual recovery was not necessarily accompanied by angiographic improvement of cystoid macular edema. Coming to the next study that was published a year later on pars plana vitrectomy, now combined with intravitreal triamcinolone. This came from Germany, and patients with uveitis, including 19 eyes, not responding to systemic steroids or immunosuppression, and they had combined their treatment with acetazolamide. This was again a retrospective series. The vitrectomy was additionally combined with an intravitreal injection of triamcinolone acetonide 4 milligrams. These eyes included 4 from chronic interior uveitis, 9 had intermediate uveitis, 3 had posterior uveitis, and 3 had panuveitis. The outcome measures were visual acuity, intraocular pressure, angiographic appearance of the CME, and of course, postoperative complications. Now, if you look at this table, if you look at the table above, this shows the course of the visual acuity over a period of time. So let's see 2 weeks, 6 weeks, 3 months, 6 months, and 12 months. If you see the improvement, that is the visual acuity got better in 11% at 2 weeks, 25% at 6 weeks. It improved further at 3 months and then started declining, came down from 42% to 18% and then 28% at 12 months. So there was an initial increase in visual acuity following vitrectomy, followed by a decline. Coming to the unchanged, it almost remained stable, 47% at 2 weeks, 56%, 47%, and 53 and 50. So the about 50% of the eyes remained unchanged at any follow-up period. Coming to the worsening of visual acuity, initially at 2 weeks, there was a worsening in 42%. It came down to 19% in 6 weeks. That means the eyes that suffered worsening of vision were reduced. So that means that there was improvement in visual acuity at 6 weeks, still better at 3 months, and then started worsening again at 6 months, which remained the same at 12 months. So this was the trend they observed in visual acuity. Coming to the trend of cystoid macular edema on angiographic appearance, the leakage of CME decreased in 50% of the eyes at 2 weeks, remained almost same up to 3 months, same at 6 months, and 44% again same at 12 months. So the leakage that was decreased on fluorescein angiography was almost about 45 to 50% at any given follow-up up to 12 months. The leakage remained changed. That means it did not remain unchanged in 42% at 2 weeks, same at 3 months, came down at 6 months. That means it was better, and again got back at 44% at 12 months from where it began at 2 weeks. The leakage was more. That means the CME worsened in 8% of the eyes at any given time at 2 weeks, 3 months, and then worsened at 6 months, and then came down at 12 months. So if you look at this, the leakage increased. The CME, the fluorescence leakage of CME increased the most at 6 months and then reduced at 12 months. They did not find any intraoperative complications, but they found cataract development or progression in phakic patients in 85% of the eyes. IOP rise was seen in 47%, of which 11% had persistently raised IOP until 12 months of follow-up. The angiographic course of CME after surgery did not correlate well with the course of visual acuity as we saw in the tables. So their observations suggested that vitrectomy with additional intraocular injection of triamcinolone may improve CME only in selected patients. However, the improvement of visual acuity and reduction of CME was only transient in many cases, as we saw again from the tables. Additional intravitreal triamcinolone acetonide given during vitrectomy did not provide a long-term improvement of visual acuity. So this was a systematic review on pars plana vitrectomy for the treatment of uveitis as a whole with CME as a subset. So this was this included 34 articles that was published from 2005 to 2004, which were included in the final data analysis, of which 32 were retrospective case series and 2 were randomized pilot studies. Overall, 627 patients and 708 total eyes underwent vitrectomy for uveitis. The mean age was 43.4 years. The median duration of uveitis prior to vitrectomy was 36.1 months, ranging from 4 to 198 months. The median follow-up after vitrectomy was 18.9 months, ranging from 2 to 114 months. The vision was reported for 519 eyes, out of which 69% showed improvement, 18% remained unchanged, and 13% worsened. Preoperatively, 52% of the eyes had a documented cystoid macular edema, compared to 37% postoperatively. The median use of oral steroids improved from 48% preoperatively to 12% postoperatively, and the median use of immunosuppressive drugs decreased from 56% preoperatively to 36% postoperatively. Although nearly all studies reported favorable outcomes of vitrectomy in the management of uveitis, the quality of data remained limited by a number of factors like a lack of application of standardized reporting outcomes, limitations in the study design, and of course, paucity of the prospective data. So to summarize, vitrectomy may have improved vision because of improvement in the media clarity, rather than specifically inducing changes to the previously existing cystoid macular edema. The mechanism of uveitic macular edema regression after PPV is not fully understood, and we don't have much evidence, but it points probably towards a decrease of the antigen presentation because of the inflammatory mediators and the vitreous in the vitreous body, which get reduced by removing the vitreous gel. Also, there seems to be no evidence so far that vitrectomy reduces the number of episodes of uveitis. So thank you very much for this opportunity. Thank you, ISG.
Thank you very much. Thank you, everyone, for a very, very informative webinar. So now is the time for controversies and what has not been covered in the webinar. So I will begin with Sapna. Sapna, there have been questions, and like we all understand, it's the inflammation. But when we talk of infections and when there is overwhelming inflammation, at that time, we generally do not see macular edema. So what is your take on that?
So it's two things. One, it could be when there's a lot of vitreous haze. Clinically, we may not identify macular edema, but imaging might be able to give us a view of macular edema. Secondly, I think someone asked this question before, is that we sometimes see macular edema develop even when there is no active inflammation going on. So it's kind of the opposite side of the same question that you asked me. And so I think overall, macular edema development is not a direct result of inflammation, but it is a post-structural change like epiretinal membrane. We can see epiretinal membranes develop in almost 40 to 50% patients with uveitis after a while of having uveitis. So I think that that's my answer. It's not directly inflammation, but a structural complication of having had inflammation.
So that brings me to Rubens, like for toxoplasma, for example, it's very common that once the active phase is over, we see the epiretinal membrane and we see maybe macular edema. I don't see as much toxo as you do. So what is your take on it? Is there something we can do to prevent the development of macular edema and the epiretinal membrane during the acute phase?
I don't think we have something we could do really to avoid the epiretinal membranes and the vitreoretinal tractions. Maybe using higher dose of steroids and treating the disease since the beginning with this amount of drug could decrease the inflammation. I believe that basically, we have known for centuries that inflammation brings edema, and brings swelling. And what happens in the retina is just a swelling of the inflammation. And the inflammation also brings fibroblasts. And with the vitreous, the tendency is that they're going to really create these membranes. As far as I know, there is nothing we can do to avoid it in a patient with toxoplasmosis. I agree that also a surgery, I believe, should be used more and maybe earlier. In many cases, I've seen many cases of vitreous opacity, dense ones, that you cannot see well the posterior pole of the eye, and a good vitrectomy is essential. But let me tell you something else very important. In uveitis, vitrectomy should not be done by people without a good experience. I see very often retinal surgeons that do not know how to handle patients with uveitis, and the result is much worse.
Yes, Rubens, that brings us to another question for you. And this is by Priyanka from the attendees. How would you treat macular edema in viral uveitis? Would you give steroids? The edema is responding to steroids. And would you continue to give antiviral?
If it's necrotizing retinitis, I believe we should avoid steroids, and we should always use high doses of antimicrobial agents. So in case of, for instance, herpetic retinitis, we use like 6 grams a day of valacyclovir. or even 8 grams a day. And we try to use it for as long as we can. And we avoid periocular or intraocular steroids in these cases. If we have to do something else, we'd go for surgery. I think surgery, endolaser, and try to control the inflammation is something very important. And when you remove the vitreous, usually the inflammation gets better.
And Rubens, if it's a case of post-toxomacular edema and you want to treat it with steroids, would you combine it with intravitreal clindamycin?
Well, I do not see very often patients with macular edema after the toxoplasmosis is controlled, except in the case that the macular edema is secondary to the vitreoretinal problems. The question is if I use association of clindamycin. Intravitreal clindamycin is a good drug. Yes, we use it. We also have used intravitreal Bactrim, and they work. They work, but I am afraid of using triamcinolone in case of toxoplasmosis because in the past we did a small clinical trial. The results were very, very bad. If I have to use steroids in this situation, I try to give a very strong antimicrobial coverage and do not use long-lasting steroids. I would go to something short action, dexamethasone, thing like that.
Thank you. Marian, you showed beautiful images. You also showed us the ganglion cell layer cysts and the different phenotypes. You also did mention that sometimes the toxicity could be responsible rather than the, inflammation. Are there any biomarkers on imaging that can give you a clue that it's toxic and non-inflammatory?
This is very hard. I was actually, when Sapna gave her talk, and she was mentioning the 3 types of macular edema and showed that diffuse macular edema. I'm always kind of struggling with that because my answer right now would have been like diffuse macular edema or like microcystic changes. However, I think it's a lot of, it's a matter of resolution because I mean, when we look at the retina, like all the cysts or all the cysts we see will kind of show up in a kind of cystic way. This is just how the way it can kind of accumulate in the retina. And it's then just a matter of how high our resolution of the imaging device is to see the cystic spaces. And a diffuse macular edema, which was kind of defined as a diffuse macular edema in the spectral domain, OCT times, will be different than a diffuse macular edema, which has been kind of defined in a stratus OCT area. So I think it's very hard to say. So, but in general, if we degenerative changes, usually if we see large cysts, on the one hand side, it shows us that there's a lot of degeneration going on because we have lost a lot of tissue, which allows the cysts kind of to form large bodies and large cysts. And on the other hand, again, like I said, there are areas and layers where fluid has a lot of trouble to accumulating, and this is like I said in the nuclear layers or like in the retinal nerve fiber layer, because like the fibers are very, very close to each other, or in the ganglion cell layer. And if you see cysts there and it's not like tractional due to tractional forces, probably there's also some degenerative causes or underlying causes going on.
Okay, now there is another question, Rima. Like early vitrectomy, though you talked about vitrectomy for macular edema, but like Sapna says and Ruben touched upon this topic, the development of the epiretinal membrane is one of the important causes that macular edema many a times comes at a later stage. So I'm coming to the medical part to Mark later, but do you think an early intervention with vitrectomy, where you have a lot of vitritis, like intermediate uveitis, in our center, we do it therapeutic all the time. Would you like to share your experience of development of ERM, and macular edema in patients who received vitrectomy as a therapy before immunosuppression?
Yeah, so generally I prefer to give steroids and then immunosuppression and then do a vitrectomy, because if it doesn't work. But I have seen in my personal experience, post-vitrectomy, the CME does come back, and it goes only with an additional load of steroids or immunosuppression. And once, vitrectomized, I usually avoid Ozurdex, but it's a good choice. But I've seen it comes back after several months, and it goes only with steroids or immunosuppression or biologicals.
So early vitrectomy is not an answer to the development. Thank you. That's very useful. Mark, now let's talk about preventing the macular edema, because we do have biologics. We are talking about anti-IL-6 and adalimumab, and especially in children. None of the talks covered macular edema in children with JIAs and with other. Do you think the very aggressive initial therapy before the development of macular edema would be a good approach in these children, rather than trying to give biologics when macular edema has come?
Well, for that's a different topic. We didn't really talk about that. But if we look at JIA over the last 40 years, there has been minimal progress with regards to results once we start seeing the degenerative changes, whether it's macular edema or something else. However, overall, patients do much better today with JIA, in part because they're referred early for treatment. So yes, if the treatment is appropriate and eliminates the presence of inflammation in the eye, the risk of getting any kind of side effect, whether it's the macular edema, glaucoma, and other manifestations, is significantly reduced. Having said that, I've seen quite a few patients with severe disease, hypotony, membranes at the surface of the retina. And if you do aggressive surgery in these cases, where you remove the vitreous all the way out to the vitreous base, where you remove the lens, and you do a epiretinal membrane peel, even though the ILM may still be more or less normal at that stage, you do end up avoiding the development of macular edema, and you end up with a good result. The problem of the edema in these children is not only the inflammation, it's the contraction of the vitreous pulling on the fovea. And this is a very attached posterior hyaloid. And if it isn't removed, you end up having edema on a secondary basis, not necessarily due to the edema itself.
Thank you. Sapna, you practice in a country where you have all the choices available to you. And we did hear from John and from Rubens that Ozurdex does not essentially have any advantage over triamcinolone, though the cost of TriSense was $110, and the preservative one with alcohol was $10. That's what John showed. Now, we have our friends from all over the world, and everybody doesn't have everything available to them. Now, suppose there is only preservative triamcinolone acetonide available. What would be your take on it? Should they give intravitreal because that's more effective? Or should they give periocular because it has alcohol in it?
I'm actually going to burst that bubble a little bit, because we have not had preservative-free TriSense for maybe 18 months now. It's been off supply, so nobody has it. But given the choice, preservative-free TriSense, if you did not have restrictions, preservative-free TriSense is significantly better in terms of it based on your point study. But whenever I have used preservative-free TriSense, I have been very stressed out, because when you look inside the eye the next day, it's full of white cells, and you don't know whether you're dealing with something like endophthalmitis. So mostly for my younger patients, I will far prefer to use orbital floor periocular steroid versus intravitreal TriSense. And I see all the panelists nodding, so I think that all of us will pretty much do that.
So Marian, would you like to comment to that? Yes, Rubens.
Well, I was just going to say that we have it in Brazil, have had it, as I said, for maybe, I don't know, 15 years, 20 years. It costs us $10. And I tell you, you inject a little bit in the anterior chamber, you inject in the vitreous, and I tell you, it works. And regarding the suprachoroidal thing, many years ago, we broke some Ozurdex in a small fragment and implanted in the suprachoroid. And it also worked very well. But because of other problems with the company, we gave up. I believe that we're going to have in the future implants also to be used in the suprachoroidal space. Thank you.
I think one.
Can I add about? Sorry, can I add about suprachoroidals? We're starting to use suprachoroidal triescents now and the Xiper, and even though it is, again, it's quite painful for the patients when you're doing this because you have to inject over 15 to 20 seconds and there's a slow distension of the suprachoroidal space. So the patients are in quite a lot of discomfort, not just during the injection, but 2 to 3 days after the injection. But I have really seen very good results with Xiper. It's too early for me to tell you what adverse events like steroids are causing pressure rises or causing cataracts are, but so far that suprachoroidal triescents results are being phenomenal.
For the sake of our friends from countries like ours, one has to be very careful while using intravitreal triamcinolone that is not meant for use in the eye, because many a times it's not really checked for sterility. The way the intraocular injections are meant to be, and we have had fungal endophthalmitis and other instances. So you got to actually look into the area where you are practicing and your local, because we prefer Ozurdex simply because we know it is sterile, not because of the cost factors, but it may vary. So Marian, what is your take on suprachoroidal? Because that's not something which is very commonly being done. And I will come to Mark because he has a lot of experience in that. But before that, if you are a beginner, there are 2 questions for you. And you want to try a new therapy like interferons topical, or you want to give intravitreal IL-6, or you want to give intravitreal adalimumab, what will be the situations that will push you into it? And what will be the situations you would prefer suprachoroidal over orbital floor or intravitreal?
Well, a long question. First of all, regarding the suprachoroidal, unfortunately, it's not available yet in Switzerland, so we can't use it. But when I was at Northwestern in Chicago, there were like the early stages of the suprachoroidal injection developments, and I've had several patients, and I can just agree that patients were in quite a pain when they received it, and the results I've seen were great so far, and of course I know the results from the clinical trials. So I'd love to see it very soon, also in European countries and in Switzerland being available. And otherwise, regarding the other drugs, I think it's a very promising tool, and I think like the intravitreal anti-IL-6 is just the beginning, because there are a lot of new developments now. For example, also from Kodiak, working on a bispecific antibody with VEGF plus anti-IL-6. There are also other companies who are working on bispecific antibodies with, for example, VEGF and anti-TNF alpha. So I think this is just the beginning, and we will have a lot of different biologicals which we can administer locally or intravitreally. So I think we will see what the best options are, and probably we will then kind of have subgroups of patients we will treat with one, and subgroups of patients we will treat with the others. Yeah.
The next question is for Rima and Mark. We did not really touch upon the hypotony and macular edema, because hypotony might occur when the eye is inflamed, or it might occur when the eye is not inflamed. So how would your approach be different in patients who have hypotony? Both of you, one by one. Rima, maybe you can go early.
So hypotony first, I would like to assess the cause and do a UBM to check for the status of the ciliary body. And if we find cyclitic membranes and ciliary body atrophy, then we need to plan accordingly. And vitrectomy is then combined with lensectomy and with cyclitic membrane dissection and followed by silicone oil tamponade to maintain at least the IOP of the eye. And if there is no membrane, the ciliary body is functioning well. And cataract, depending upon the status of the cataract, we can just do lensectomy or vitrectomy, but I would not go for an intraocular lens, even if there is no cyclitic membrane. Because once the hypotony has come in, I think we are heading towards that stage. So it's better to play safe and avoid an intraocular lens. And yeah, vitrectomy and lensectomy is a good choice. And
Mark?
Sorry.
Yeah, so my approach is quite similar. I start by using steroids, though, to see if there's any inflammatory component that is residual. I'd like to know how much function there is inside the eye. And sometimes just giving them steroids for a month or two, you see a pressure rise. And so then it's a different story. Plus, what is hypotony? For me, that's 1 to 2 millimeters of mercury. If we're at 4 to 6, there are some eyes that do perfectly well, and we can just keep them on some anti-inflammatory medication. If there is hypotony, yes, the UBM is important. If you see ciliary body present, I would remove all of the membranes, and that's extensive dissection. I'd remove the lens if it's present. And I don't put silicone oil in. I live with a slightly lower pressure. The reason being is that silicone itself has a tendency to destroy part of the epithelium of the ciliary body. If there is nothing during surgery, if I see no, ciliary body structures, we've lost the structure itself, it's flat, then I'll use silicone oil because there's no chance of getting any function. But that's on the only circumstance I would. And that's the time when you need the silicone oil because otherwise the eye starts to shrink.
One last question to all of you, one by one. When do you give up? Like Mark showed that there is a time when you say, no more. So what is that time for you? There is no inflammation in the eye, just the macular edema, which is not going. So when do you say, nothing more? We begin with Rubens. He's the wisest of all of us.
Well, you always have to take in consideration if the disease is unilateral or bilateral, the age of the patient, for how long you expect him to live, and what is the impact of this on their health, on their quality of life. Very often we end up in situations like that. I'm happy that you did not ask the questions about hypotony for me, and good to see that my old professor Mark Decimé covered so well. So it's a tragedy. You do everything. I've injected steroids every week, trying to see hyper, and never happens. So it gets to the point that, yeah, you have to say it's done. It's up. We talk a lot about humanitarian medicine and palliative medicine. We have also to think about palliative ophthalmology. There are situations where continue the treatment without a chance is bad for the patient. And we physicians have to assume that we have sometimes to give up and tell them the truth to the patient. I see patients sometimes operated 10 times without a chance because the ophthalmologist does not resist this very sad position. And yes, I think, Vishal, your question was very good. Doesn't matter what you try to do, sometimes we have to just throw the towel.
Thank you, Rubens. Anybody would like to add anything?
So if a patient presents to you and they seem to be chronic, and it's an end stage, I think we should, as Rubens just mentioned, give them still the benefit of the doubt, at least when you first see them. And so then what I would try, based on their age, their ability to tolerate, is try to give them a shock treatment to see if you get improvement. And that could be, for example, pulse steroids. You know, just see whether you're going to get a response, or treat for a while with maximum dose of one or the other medication for 2 to 3 months and see what happens. And if that doesn't work, I think then you have to talk to the patient and say, listen, the medication is too toxic, you're going to get side effects, we should try to stop. And what I did mention was, trying to stimulate the RPE pump. And in some of these conditions, if we use that, although it's not cheap, it can reverse the problem and improve and give them a slight improvement in vision.
Yes, Marion.
One thing I want to add is I usually don't give up on my own. So before I do that, I would definitely consult like colleagues, friends, people with a lot of expertise who may have been in the field for a longer period of time to really make sure that I'm not giving up just because of the fact that I missed something or I forgot something or I wasn't thinking of some potential other methods.
Sapna,
I
have
like
you
that,
ever
Marian.
tried?
So that's why you have Rubens and me with no hair anymore.
Sapna, yes. Have you ever tried dorzolamide, that thing like that, to improve the pump?
So I've tried acetazolamide, oral Diamox. I've tried dorzolamide drops, and I have some, especially in some children, it's been quite resistant. The one comment I wanted to make was when I reached this point where I have had a second opinion and I have tried systemic medication, I've tried local therapies, I've tried regional, and I'm ready to give up. I have the luxury here of referring the patients to a low vision specialist, because what I try to impress upon the patients, almost like macular degeneration, because our patients are younger than the macular degeneration patients, is that they have very good peripheral vision. It's their central vision that's not good. And if we can overcome that with low vision aids, then at least they have a better quality of life versus me continuing to pound them with more toxins. And I have found that simple magnifiers, it's not even like many of my patients, they just go to Amazon or something and they buy magnifiers and they are significantly happier with that. Also with uveitis, more commonly it is unilateral versus bilateral. So many times the low vision specialists, they work with the patients on trying to do something like a monovision, where they focus one eye for distance and they give them glasses or something else for near vision, and they try to optimize it. So things that I don't think of as a uveitis person, sometimes an optometrist can, with really clever use of glasses and contact lenses, can make a patient's quality of life significantly better.
That's really important. We all do low vision for AMD, but somehow forget it for our uveitis patient. Yes, Mark.
I think the other thing is, these patients that are so advanced, they may have lost the macula, but they're also in a very fibrotic stage, which is what happens when you're in end-stage uveitis. And so even though we stop with the uveitis, it doesn't mean we have to forget they can get glaucoma and other problems. So they still require adequate follow-up by somebody, whether it's still in the uveitis service or by their local, ophthalmologist.
Well, that brings us to the end of a very, very interesting webinar. Thank you all for being there. And we now have 2 months of break. It's summertime. Enjoy time with your families. And we will be back on 3rd of September with a very important complication, cataract and uveitis. So this is cataract and October is glaucoma. And then hopefully in January 2024, we will come up with a new set of series, probably discussing cases of each of the entities that have been, discussed over the past 30 months. Thank you very much, everyone. Have a great summer break. And thank you, panelists, for being with us on Saturday evening. Thank you.
Nice to see everyone.
Thank you. Bye. Thank you.
Congratulations,
Bye,
guys.
Thank you.
Very good. Excellent.
Thank you. All the best.
Thank you. Bye-bye.
Have a nice weekend. A nice weekend.
You
Bye-bye.
too. Thank you. Bye.
Bye-bye.
Rubens. Bye.
Bye, Mark. Take care. Bye-bye.
Take care also. Bye.
So Ruben is going to give us the history, Mark. So you have
Very
Excuse me?
good.
You have to remind him. You
I
have to.
will.
Excuse me?
No, Rubens, we need, in our new website, what we're going to do for the internal, for all of the IUSG members on the website, I think we need a section on the history of IUSG. And I was discussing with Vishali, I can't think of any better person than you to, try to write the history of the beginning of the IUSG. A good organization needs that also, don't you think?
Well, I already received this information from our president. I told her yes. The problem is that that my age, a lot of things that I knew, I already forgot.
Yeah, but you still know a lot, Rubens. You just showed us, so I'm sure
You
that
have to
No,
ask.
no, no. No, but I would like I can help. It would be a pleasure. I suggest her maybe. I don't know if Blanc Michel is still around.
No, he's passed away. But you
Oh, he
know,
passed away.
do you know if Khalid is still around? Because Khalid would be somebody who could also contribute, I think.
He's around. He's around. We should get in touch with him.
So we can get in
Khalid
touch with him.
and also Matti, and also our
Of
friend
course.
from Finland.
Yes, of course. So maybe we could,
Okay.
Vishali, try to organize a telecon and
A
sort
group.
of discuss and then try to, as a group, and then see how we can arrange this. Because, you know, on the internal website, what I would like to see is that we have a section for members where we have the history, where we have, you know, maybe publications from the members, all of the committees that we have. We should put the bylaws there, all of the information that relates the list of our members so that they can have access to it. So that and then we've already started, for example, a section on good images. And all of the webinars, of course, are available for other people, but they should be available to us too. So one part, I think, is the history, because we're getting more and more. This year, we're getting a lot of applications for new members. And, you know, the history of the IOSG is going to be lost otherwise. And, you know, it's an organization that is there since 1978. We should get, you know, some information.
Do you have a list of the members of at the time they joined the society?
We have from about maybe 7-8 years ago. I don't have from the early days because the only thing is I don't know whether in the Red Book, I have an electronic version of the Red Book, but I don't think it mentions when people joined. I don't even remember when I became a member. You know, it took about 2 years to put me on the mailing list.
Yeah, I still have a flyer of the World Uveitis Congress that we did in Guarujá in 1970s. Yes. I'm going to take a look of the members we had at that time and see the other survivors.
But even, you know, something like that flyer is already interesting. You know, if we had flyers of all of the meetings that have occurred, and we sort of put that into a this history part, that would be great. You know, I have the original, a copy of the original submission by Blanc Michel to register the IOSG. You know, in some ways, these archives are sort of interesting, not necessarily for us, but for future generations.
Agree. Yeah. The idea of the flyers maybe would be a good one. People that organize the flyer could send information, and yeah, great.
We will do that. Yeah, we will form a group,
okay.
And then we will take it forward.
Okay, good.
Yeah.
Thank you.
And maybe also have some real meetings together in one of the Congress. I don't know, that we could advance it. Okay, my pleasure.
Of course, yeah, great. For sure.
Are you coming to IOIS?
No, I can't. I'm so busy with a lot of things. I just came from Amazon. I spent a week there, Mark. And we have a project now going on there. It's very time consuming. I cannot be everywhere. And frankly speaking, there are some places where I gave up because I pretend to teach. Some people pretend to learn. And it's a waste of time very often, I see. And very expensive, very expensive.
Very expensive.
Yeah. Flying to these meetings, it became very, very complicated for most of the people.
Yes.
I agree. But, you know, I still have to come once to the Amazon someday.
Oh, yeah. So actually, it's rain check. We have a program now. It's a program now we have going on there. It's not very important for uveitis, but for ophthalmology, it's great. You'd love it. Michelle, you'd see so much water. I've never seen so much water.
There is a comment from Dr. Enka Stenovic. She says, I'm Professor Dr. Enka, and I have the information on IOSG since 1978, as I was one of the founding members. Wow, that's so special. Mark, can you go to Q&A and pronounce pronounce
What
the
is the
name
name?
correctly?
Anka Stanojevic. Stanojevic Pauvic.
Pauvic.
Well, if she is, she should get in touch with us.
Yeah, can we get your email, please?
Yeah,
I never heard that name.
she's from Serbia.
From
don't know
Serbia.
Well, frankly speaking, she may be confusing the IOSG with other organization.
It could be, but let's have a look. I mean, I have the list of all members here, and I don't remember seeing her name on it. I know she's there. She's there. Yeah, she's there. She's on the list.
1978?
Oh, we have her email. I'll just copy that email and then we will get in touch with her.
Yeah. Okay.
Great.
Well, that's
Well,
good.
I think I never heard it.
Yes, you are on the list. I can see that.
Yeah,
I
you're
have
on
the
the
list in
list.
front of me.
So probably we need to reach out to all our members and say that whatever memories and photos and information you have, please share. You know,
Yeah, and
besides
the others, I
those-
think we should ask people to tell us what their what year they joined, if they remember.
I don't remember.
Yeah, neither do I.
It would sound impolite, but maybe I should ask a picture of her at that time, so we'd see. Not from today.
No, I agree. Okay, well,
Okay.
Take care. Bye-bye.
Bye.
take care.
Thank you so
Yeah.
much. And
Thank you very much.
hey, congratulations
Thank
for the
you.
great job
Thank
you're doing. Congratulations. Bisha, it's
Bye.
good to see that you put Mark to work. Excellent.
What do you mean? What do you mean? She's giving me a hell of a lot of work, you know that?
You both, not kidding, you both are invited to come to the Amazon anytime, you know? From Amazon is not so difficult anymore. There are jets every day, and you
Wow.
love the experience.
We
I'm
will
sure I
plan.
would.
We will
just
plan
have to
an
be able to get
IUSG
there.
course. We will plan an IUSG course in Amazon.
In the Amazon, yeah.
Would be great. Brazil is gonna invite AOS to come to Brazil and for Rio de Janeiro, and maybe, I don't know, if they do it in a few years, we could have another meeting before or after in Manaus. I don't know.
That's a good idea. That's a good
idea.
idea.
I'm always open to have meetings in unusual places, right?
So do I.
Dr. Anka said
Yeah.
she took the photographs when they came to Serbia and the old ones. So we will get in touch.
Okay, good. We'll do that.
After
I think
the
that's
Perfect.
that'll be the best thing.
Bye,
Bye.
guys. Wonderful.
Take care.
you.
Thank you very much.
Thank you so much. Bye-bye.
Yeah, take care. Bye. Vishali?